I think everyone is getting inside the room already. I think we plan to start on time at 2 p.m. this afternoon, so that because we have a lot of experts lining up to share with us about the experiences and expertise here. But before that, let me probably say hi. Good afternoon, everyone, and welcome. It is my pleasure to welcome you and have you all here in this session. I think it's a very long name. Is AI a panacea for the health sector? Navigating the barriers to adopt AI to strengthen health system and empower limited resource setting. As we all know that new technologies, AI, digital health, they are emerging a lot these days, and in a way they have shifted the way that we work, especially in health sector, the way that we manage our resources, handling patients, all of this, delivering the healthcare services, for example. But yet, in many resource-limited settings, they experience, challenges a lot, And that brings us to this session where we would like to learn more about experiences of these global challenges in terms of adopting AI into their health systems. But as also to mention that what we are going to talk about this afternoon, it would be built based on all the discussion, the dialogue that has been happened throughout 1.5 days in the past. But we would really focus on 3 key elements in this afternoon. Yeah. Oh, there's no key 3 elements here, but let me talk about that. So we have one is data security themes. Second one is regulatory framework. And the last one is about economic infrastructure that relate to this AI adoption, right? Yeah, that it would be 3 main key themes for this discussion this afternoon. But before that, let's freshen up a bit. Okay, shall we? I'll pass on the torch to our ladies here.
Thank you. Good afternoon, everyone. So as Manit already mentioned, that we're going to have a little bit of activity. So just to get everyone a little bit fresh up after lunch, yeah?
Yeah.
Okay, so we want to get to know you better. So please grab your phone, your laptop, and your tablet, so to scan. Oh, sorry. So we will use Menti for today's session. Okay. Here, please scan QR code to get access, or you can just join by go to our webmenti.com using the code there.
Yeah, okay, that's right. You also will appear live on the screen, and so let's see how creative and insightful our team can be. So
okay, so if you already here, please give us a thumbs up or maybe a few buttons if anyone feels a little bit sassy.
The cat one or anything. Yeah. But if you have any problem, you can raise your hand and our team will go straight to you. Okay.
Anyone have a problem get into Access Menti? Please let us know. Our team will go direct to you.
Yeah. Okay.
Okay, now we've got about 30 people now.
Yes.
Okay,
30.
shall we start now?
Yeah. Are you ready? I think.
Yeah.
I think we are ready. Okay. Yes. So here go to our first question. This is the easy one. Okay. Yeah. Okay. Where are you from? Oh, sorry.
Sorry,
yeah.
sorry.
Okay. Sorry. Yeah.
Okay,
where are you
so-
from?
Yeah,
Okay.
just drag to where the continent or the country where you're from. The
Yes.
other map. It might be a little bit
Yeah.
so small, but
Yeah.
please. Yeah.
So sorry. Yeah. You can put
Yeah.
like your finger on the screen. It will pin.
Oh.
Yeah. Oh.
Wow. Where's that continent?
Yeah,
I don't
we
know
got-
exactly.
Yes. We got some
Okay.
from. We got a lot from Thailand. Yes, for
Yeah.
sure.
Okay, I think we've got such a diverse group today, as I can see. Some people from that small little island where I don't really.
We're not sure. Sorry.
Yeah. Yeah. So
And we got
Wow.
from Japan, I think.
That's
Oh.
very diverse. Okay.
Yes.
Well, thank you for sharing where you're coming from with us.
Yeah.
I think we got everyone here.
Yes.
Yeah?
Okay, so we go to the next question. All right, moving on our second question. And this is the fun one. Okay.
Okay. We still have more to come.
Yeah. On a scale from Nicolas Cage, how are you today?
How are
Yeah.
you feeling today?
Yeah.
Seeing from here, happy,
Yeah. We got a lot of
carefree?
mood. Yes.
Oh,
Oh.
wow. Everyone say me. Like,
Oh. Oh.
excited. Oh, glad to hear
Yes.
that.
Okay. It seemed like we got a lot of excited, Nicholas. So whatever your case energy is today, so we are glad that you're here and ready to have some fun with us.
Okay, exactly. Whether you feel chill, excited, or may, or peace, or angry. Some
Yeah.
people angry in this room. Wow. Wow. Okay. Anyway, this session is going to be exciting, right, for everyone. So now let's get into today
Yeah.
theme a little bit more for our next question. So we want to know. Okay, next question. Okay, so we want to know how often do you use AI? So
Yes.
you can choose from every day, a few times a week, once in a while, rarely, or never. So let's see how AI fits into everyone's life.
Yes.
Okay.
What about you, ค่ะ พี่ไอติม
Actually, in my work life, I use it every day.
Yeah. I think we are all, yeah.
Yeah, I think we all use every day as like
Yes.
a researcher.
Yes.
Yeah. Okay.
Okay.
Here. Interesting. It seems like we got a good mix here. Some people say like every day. Most of you said every day, right?
Yeah.
Most of you as well said a few times a week, right? So, well, no matter where you stand, so today's session is about to exploring the key challenges in adopting AI to strengthen the health system. All right?
Yeah, exactly. Now we will go to our final question. Yeah. Please rank the areas where AI will have the biggest impact in the future. So our options are transportation, education, healthcare, environment, business, entertainment, and privacy and security. Oh, we got the privacy and security in the first one, the first right. Oh, and business
Interesting.
is the
Wow.
Yeah.
And healthcare is now.
Okay. Okay.
Right. I think, okay, that's good to know that everyone thinks business industry
Yeah.
is like, oh, it's coming out. Wow,
Okay,
education.
okay.
Okay, I think,
Yeah.
well, I think that is all. I think
Yeah.
we now warm up after our lunch. I guess everyone have like fresh eye now and ready to explore the key challenges in adopting AI in healthcare for today.
Yes.
Okay. Let's get started then. I'll hand over to Manit, our MC today. Yeah.
Thank you.
Thank you very much indeed for the introduction and a refreshing up for today. Yeah. So next slide, please. Today we are very fortunate to have a lineup of these diverse experts from different countries. I'm not going to introduce them now because I'm going to do that before their presentations. Let them a bit of a break because they fly over very far, and that is me, but doesn't look like me now. But that's okay. Yeah, I'm very pleased to meet you today. So be mindful of the time. We would like to begin with a bit of, opening session. We have received the honor from Dr. Surakamhet Mongkonchoo, Director of Technical and Planning Division, the Department of Thai Traditional and Alternative Medicine, Ministry of Public Health, Thailand, to deliver the opening remarks. I'm excited. Nicolas Cage now. Dr. Surakamhet has been a leader in advancing technology, health technologies, and we are privileged to hear his thoughts on AI potential and challenges in healthcare. Please join me in welcoming Dr. Surakamhet to the stage.
Oh, yes. It's the very honor to be here as the keynote speaker. So I have 10 minutes, which I think I will just opening up for the scene so that other speaker will present what they are having on the thought on AI and barrier and implementation. So I just want to show you what I think that we could be used, what I think AI could be used in helping solve a lot of health sector problem. So the topic is about panacea, right? So can AI solve everything in health sector? And I will spend 10 minutes to propose what can be used by AI to solve those kind of problems. So, just to declare, all my slides were made by ChatGPT. And a bit of the background, we have the Sustainable Development Goal, which is every country would need to, achieve that goal by 2030. Thailand has not been so bad in SDG. We has the index about 74, and we are ranking about 40 in across all the country. What we are not good at is number 3, which is health, and number 10, which is inequality. And those are the key things that Thailand would need to do. If we want to solve anything in the health sector, then we have to do number 3 and number 10, because number 10 eventually related to number 3. Inequality is the problem to health, for sure. And one of the SDG problems that we had is tuberculosis. Tuberculosis is SDG. If we want to achieve from red status to orange status, we have to reduce tuberculosis below 75 per 100,000, which means that current TB case around 100,000 a year in Thailand. We have to reduce them by 20,000 or 30,000 a year, which is impossible because no country can do that within like 2 or 3 years, reduce TB by 20%. But we have all the technology to do that actually, because right now we can use AI to read every chest radiography to detect tuberculosis. In municipal public health, we are doing chest radiography, 10 million chest radiography a year. I guess that only 50,000 something or 500,000 something that went through AI. 90% of chest radiography in municipal public health did not went through AI to detect tuberculosis. So if patient came to us and they had TB, we didn't detect them. But we can do this because is it feasible? Is it economically cost effective? Is value? The problem is only implementation. Okay. Then if we detect all the active tuberculosis case by AI chest radiography, we can use AI to predict who else is going to have tuberculosis at higher risk. Because the close contact of active tuberculosis, we can connect them to the address, to the family history, to the data in electronic medical record. We didn't do it now, and we can do it because the data is already in our hospital, in our national electronic medical record, but we never try to link them up. So if we have a model, we put the data, then we come up with the predictive score for each individual in the population for tuberculosis at risk. Then we can let them come to AI chest radiography, identify additional active cases. And for those that is not active tuberculosis, we ask them to go for latent TB infection screening, and that is the second cascade. Then we can also use AI to monitoring the treatment adherence, the active tuberculosis, the LTBI patient. How can we let them alert every day that they have to take tuberculosis medication? We have mobile application, and we can put this into more prompt or whatever mobile application that we have, and that is part of the AI. We can also predict who is going to I have only 3 minutes left. Okay. But that is only for tuberculosis. The data can also use for big data, the dashboard. We can provide the data to every level of healthcare to see how the TB control situation is going on in their level of healthcare and public health control. This is made by Sora AI. So it's 5-second video clip that you can just put the prompt and then they made this for you. And I just show you that how AI can do this for us. We can use this to communicate anything, everything, and we can communicate it very effectively. And what we can do next is how can we solve the problem of road traffic injury. And this is also came from AI. The solution that I listed here is not from my idea. It came from ChatGPT. I just listed here what ChatGPT said for us. And with little modification, we can put this into the idea and we can communicate more effectively. And another problem, I'm not sure we can do it or not, but Thailand has the problem of drug abuse. So that is something about the social inequality that we need to solve it. Because TB is linked to this problem. Road traffic injury also linked to this problem somehow, you know. Because those who had higher risk of traffic injury is the young individual who rode motorcycle without helmet. Those are at-risk population that we need to give them the support, the social support that they need so that they can get out of the inequality problem in the society. And this, we need to do many things like privacy, security, bias, workforce readiness, ensuring equity and ethical clearance to make that AI everything become feasible and implementable in our country. I just want to show this picture. I went to UAE in 2018. They had Fourth Industrial Revolution Institute in UAE, which they adopt from the Fourth Industrial Revolution Institute in Geneva or something. That institute worked to develop legal framework for new technology. I was invited there to develop, introduce Genomic Thailand for them so that they develop the legal framework for genomics data usage and implementation. And I think we need, they're also doing AI in UAE as well. Since 2018, in Thailand, we don't have this legal framework institute for new technology. And those are the things that we need to pass through the barrier to implement everything that we know we can do. I think everybody in this room know very well what AI can do. But how can we make it possible for the whole workforce to do it with more efficiency and solve the health sector problem? That is what we are going to discuss today. Thank you.
Thank you very much, Dr. Surakamhet, for laying down very good foundation for our discussion and 3 themes that we're going to talk about. The keywords I heard from him is pretty much about implementation issues as well in this case, right? But also, thank you for sharing a lot of case studies from using AI to support the TB detection and on the road traffic injuries and also the drug abuse as well. So, but also to remind all of you before we begin our presentation on 3 themes, we have set a whiteboard at the back of the room in case any of you are shy to ask on microphone, so you can write down your questions based on those themes as well. But otherwise, we could also ask on the spot as well. Okay, so we now move to the first session, the first theme of the discussion, focusing on data security and privacy. This session, we would explore how AI adoption in healthcare can address data security concerns while ensuring privacy too. We are thrilled to have 2 speakers with us, but the first person is Mr. Khachon Mongkonchoo. Mongkonchoo, Director of the Intelligent Data Innovation Division, National Health Security Office in HSO, Thailand. Please welcome to the stage Mr. Khachon, please.
สวัสดีครับ and good afternoon, ladies and gentlemen. My name is Khachon Mongkonchoo, and Director of the Intelligent Data Innovation at HSO, Thailand. It is an honor to be here. This is the first time for me. It is an honor to be here at this PMAC site meeting to share HSO's experience and insight on how we advance the health security system while ensuring data security and privacy. Let me start by giving you a little context about NHSO. We are the organization responsible for managing Thailand Universal Health Coverage Scheme, which provide healthcare services to about 48 million people. As you can imagine, to manage healthcare system for a large population will generate enormous amount of sensitive data in every second. The data that is critical to providing care, but they must be protected at all costs. Today, I will show how NHO covered it by balancing innovation and security to build a resilient health, better health system. So, this is about core business of the UC, that the core business of NHO. In every aspect of the NHO core business, rely on the data and information. From strategic planning, registration of health service provider, enrollment of beneficiary, fund management, health service quality control, and consumer protection. This area work together to ensure the universal coverage scheme delivers comprehensive health benefits. For example, the first yellow box, registration and enrollment data, contain all detail about personal information like name, ID card, and demographic detail, which is important data for confirming people's medical treatment benefit. And the service data or claim data, we collect all outpatient, inpatient, and P&P services from the healthcare facility that they submit to us. This data is essential for claim and reimbursement system and for analyzing and improving service quality. Moreover, we also have the CRM data from hotline 1330 that the people call in to inquire or request assistance. The data system and IT infrastructure is underlying all this operation, serving as a key driver of NHO mission to achieve USC effectively. Next slide, please. So, let me drill down moreover about the registration data. We have data sharing across schemes. One of NHO's key achievements is our role act as the National Beneficiary Registration Center or NBRC. This initiative began in 2015 when the government assigned us to address issue of the data duplication, inaccuracy, and delays in beneficiary and provider registration. To solve it, NHO worked with multiple government agencies to merge and integrate beneficiary data, that's including the civil registration office for daily update on birth and death data, the Comptroller General Department of Record, that we get the record of civil servant medical benefit, the Social Security Office for the individual data of the people in social security scheme, and another organization for independent health benefit package for their organization. Through this collaborative approach, NHO has ensured accurate, update, and comprehensive data to support efficient access to healthcare and reimbursement process. Let's go to next slide, please. For the medical service reimbursement system or our claim system, we use standard dataset for consistency and enable real-time claim processing via API. And we have centralized medical claim audit for verification. And moreover, we also have the next slide, please. We support citizen and provider through the Smart Contact Center 1330, which include voice and non-voice channel. For non-voice channel, we also have the Line and Facebook to we will help people to ask us via the non-voice channel. This system can reduce delay and ensure transparency and uphold public trust. Next slide, please. For the data that we collect, we construct the individual health profile to consolidate data from every citizen, including outpatient, inpatient, and PNP service. This profile provides a lifetime record of healthcare interaction from birth until death of every people to ensure better continuity of care. By securely managing and integrating this data, we support both personalized health management and nationwide policy planning. Let's focus about AI. NHO is leveraging AI to enhance the efficiency of our business. We are currently developing AI application in three purposes. The first is AI for claim processing. We use AI to review the medical claim to detect anomaly, ensuring faster processing and fraud prevention. The second purpose is Gen AI for citizens. We use AI to improve access to healthcare services and provide personalized health information to citizens via chatbot. And the last one is Gen AI for NHO staff. We support our staff to using Gen AI in their daily routine and enable data-driven decision making. These three applications enhance efficiency, improve service delivery, and ensure privacy through the secure data sharing. And we also have the data anonymization during the AI training model. Yeah. And why the data security is critical? To handle the data for about 48 million people, it means that it oversees extensive quantity of sensitive information. If we lack of the extensive protective measure, we may face the risk such as the data breaches, violation of patient privacy, and a loss of public trust that we don't want to see. To mitigate this risk, we prioritize the data security and privacy as the key component of our operation framework. Next slide, please. Our cybersecurity strategy is based on 5 principles: from identify, protect, detect, respond, and recover. This framework aligns with the Cybersecurity Act and PDPA and is certified under the next slide, please. Under the ISO 27001 to ensuring compliance with the global standard. And moreover, we also have a partnership collaboration with the national agency like NCSA and PDPC and another tech provider. The challenge remains, including scaling security across systems to ensure consistency and interoperability in data security across this system is challenging. And complexity of compliance because we have to align with multiple regulation, for example, PDPA, ISO 27001, while we have to maintain operational efficiently. It's very challenging, and increasing stakeholder awareness and addressing AI-driven cyber threat. And next step, to address this, we are expanding cybersecurity training to all of our staff and partnership. And we are adopting ISO 27701 and leverage AI for proactive threat detection from our security tool and fostering cross-sector collaboration. Yeah. In conclusion, data security and privacy are the foundation of the USC. By building secure systems and fostering trust, NSO is creating a resilient healthcare system for the future. We are committed to integrating these components to deliver healthcare that is both advanced and secure. And finally, I may leave you with this thought. Innovation without security is fragile, but security without innovation is stagnant. Thank you.
Thank you very much, Mr. Khachon. Now we just heard about the case study. I know I've been warned about the light. The case study from Thailand about how they manage the security, especially the claim data, which is a very large data that we have from NHSO, and also share a bit more the key challenges too. Thank you, Mr. Khachon. Our next speaker, under the same themes of data security and privacy, we have Professor Nam-Kyong Choi, Chairperson, Department of Health Convergence, Ewha Women's University, Korea. So please welcome Prof. Choi.
Good afternoon, and thank you for the kind introduction. And my name is Nam-Kyong Choi, and I'm from the Department of the Health Convergence at Ewha Women's University. It's really an honor to be invited to this esteemed meeting, and I'm delighted to have the opportunity to present on the topic of the data security and privacy using Korean public big data. So before diving into the details, I'd like to express my gratitude to the HITAP Foundation for organizing such an excellent meeting. Next, please. Yeah, it's okay. Yeah. To briefly introduce myself, I earned my undergraduate degree in pharmacy from Ewha Women's University, and later completed a master's and PhD in pharmacoepidemiology at the College of Medicine, Seoul National University. And my research focuses on the pharmacoepidemiology and pharmacovigilance and the vaccine safety. And I'm particularly dedicated to utilizing real-world data to generate real-world evidence to support the evidence-based decision-making and advance healthcare insights. So today I'd like to, please. So today I'd like to share insights on how Korea effectively balances privacy protection and regulatory compliance while making healthcare big data accessible for research purposes and particularly leveraging Korean national claims data. Yeah. And I'd like to introduce my department and the former one, please. Yeah, forward one. Yeah, and our department at Ewha Women's University has a history of over 60 years establishing itself as a leader in health education in Korea. So we are committed to evidence-based health policy development and personalized healthcare information services for digital era, and interdisciplinary innovation to nurture future leaders in health convergence. So next, please. So interestingly, today coincides with the Lunar New Year, the most significant holiday in Korea. So that despite the occasion, we have made the effort to join this meaningful meeting. So our department has 5 professors, including myself, and I'm delighted that 3 of my distinguished colleagues are also here today and back of the meeting rooms, and Professor Hae-Kyung Kim, and Professor Jung-Eun An, and Professor Mina Park. Yeah. Thank you. Next, please. Okay. And yeah, okay. Let me begin by providing some backgrounds on Korea's population and healthcare system. And Korea has a population of approximately 52 million people. Next, please. The country boasts remarkable achievement in health and longevity with a life expectancy of 84 years. It's significantly above the global average of 73 years. So the Korean women live in average of 87 years, and men live 81 years. Next, yeah, okay. And one critical aspect of Korea's healthcare system is the resident registration number system. It's a unique 13-digit identification number assigned to all residents. So this system links the National Health Insurance database with the most public data held by government agencies and enabling efficient integration. However, health data is strictly protected under the Personal Information Protection Act, ensuring that linkage is only allowed in specific cases with a stringent safeguard. South Korea operates a universal, single-payer healthcare system with mandatory participation. The National Health Insurance Service, we call NHIS, covers all citizens, while the Health Insurance Review and Assessment Service, we call HIRA, manages claims and reviews. So both the NHIS and HIRA systematically collect healthcare data and creating databases that are invaluable for research. Next. The NHIS and HIRA databases are classified into customized research databases tailored for specific studies and sample research databases, and which are standardized data sets, and both formats ensure anonymity while allowing researchers to conduct meaningful studies. Researchers can apply for access to these databases via the respective NIHs and HIRA websites, and streamlining the application process. Applicants must submit a study protocol, an IRB approval letter, and research product summary. And depending on the type of research, it's policy and academic or collaborative ones, and requirements in data scope they can gather, and fees are vary. Okay. Okay. Yeah. Next, please. Yeah. After the submission, applicants are reviewed by monthly. So customized data construction typically takes 4 to 6 months, and requiring researchers to visit the NIH's headquarters in Wonju City for final verification. In contrast, sample research databases are processed much faster and typically within a week of approval. Next. And data security is a top priority. So the personal information, such as identification numbers, is encrypted. And NIH limits access to customized data to each analysis center, and while HIRA permits remote analysis through pre-approved static IPs. Next, okay. And strict regulations are applied to the export processes. And raw data cannot be exported under any circumstances, and only analyzed result tables can be exported. and even this process is strictly regulated. For the NHIS, the use of electronic devices and photography is strictly prohibited in the analysis center, and the maximum daily export size is limited to 25 megabytes. And for the HIRA, the daily export limit is 300 megabytes with a maximum of 10 megabytes per file. Next. In Korea's 3 data privacy law, they are revised in January 2020 and introduced a significant update to balance data utilization with privacy protection. The law introduced several key features. And first, allowing pseudonymized data for research without individual consent. And second, strengthening privacy measures to minimize misuse risk. And third, enabling integration pseudonymized data across organizations via authorized agencies, fostering comprehensive research. And following these amendments, Korea has launched the National Big Data Platform, integrating health insurance data with other data sets from other organizations and hospitals to support public health research and policy making while ensuring robust privacy protection. And this slide shows the data life cycle, creating, sorting, storing, handling, sharing, archiving, and destroying data. And a comprehensive system managing each stage ensures data security and privacy protection, especially when handling sensitive healthcare data. And this balance allows us to protect the privacy while leveraging data for valuable research and policy making. Okay, yeah, I put my questions, but it may be moved to the last. Okay, thank you very much.
Thank you very much, Prof. Choi. Yeah, it's very nice to hear about a case study from Korea in terms of how claim data can be used. But I know that raw data can make a bit of, change. But what matters is how can we use that too, which we have heard from Prof. Choi in terms of the methods that they are implementing in the country, and also a bit mention of the privacy law of the country as well. Yeah. Since we now conclude the first theme on data privacy and security, now I would turn to the room, whether you guys have any question for both Mr. Khachon and also Prof. Choi as well. And if you're shy, you can also write down on the whiteboard at the back of the room as well. Yeah. Anyone have any question? We have about 10 minutes before we move on to the next theme.
Hi, I have a questions about using the health record data, right? So pseudonymization is nice. You can hide who they are when you hide their personal data. But there's a little bit of the tricky part where sometimes your health record can tell you who they are still, even if you hide the personal information. Because if it's a rare disease case, or if they are like the oldest person in the country, for example, then that would show you who they are, right? So is the law in Korea has some form of regulations on what is the level of pseudonymization or, the identification that would allow them to do that?
Okay, thank you very much for a nice question and very good question. And actually, all the privacy, the privacy level of the individual, the identification number are anonymized, and also the hospital code or the other very sensitive ones are anonymized. And you may be mentioned about the very rare disease, and the really rare disease are marked. And sometimes we cannot access to the rare disease data set, but sometimes at some very special occasion when we really need to develop some kind of evidence from the rare disease, we submit the protocol to the agency, and they review all the sets, and they review that is for the result is for the public advantage. At that case, we can use the data, but after all, we just access the raw data, but we cannot bring out the result, the raw data from the outside. So we can just bring out the result tables from the HIRA or the NHIS.
All right. Sorry, but that's very good. Very good information to know. But I think my questions was a little bit more about what if, let's say it's a very rare case. Let's say it goes on the news. There are very rare cases, like they're only like the first person in Thailand or in Korea that contracted this disease. Of course, when you go in, you don't see the name, you don't see like who they are, but you see that there's one patient record that has this disease. Or there are only like a few people in the entire country has this disease. So you'll be able to tell if it is them still, even though you don't see their name, you don't see the hospital, but because it's a very rare case, you still can identify who they are.
Yeah. In that case, mostly we cannot access the data because if for example, it's a very sensitive disease they have, like the dementia, or not all the dementia, but some kind of psychotic disorders, like the F code. From the IC code, they have the F code. They are marked them all that. So sometimes, usually, they do not give all the data sets from the very sensitive health information from the data set to the researchers, but very specific conditions. If the government really want to see make some policy for them, and in that case, we can have some kind of collaborative research with the authority. So in that case, we can analyze the data. But actually, we really focuses on we can't find out them individual from the data. Yeah, that's the very big priority.
Okay, and I have another question. Sorry. So the stuff about pseudonymization. So the data, like the health data, come from many different sources, right? Different hospital. You don't really want to tell anyone who this patient is, so you pseudonymize them. But as you mentioned, it has to be linked across hospital or across like different information source, so that will be useful. So do you have a central authority or someone that does the pseudonymization for you, so that at least even if you don't know who they are, you know they are the same person?
Yeah, it's a really important question. Actually that's the point of the amendment of a new law in our system, because of we sometimes do some kind of anonymization before. It's kind of, we cannot refine them again, but after the law introduced and amended, we have some kind of pseudo-anonymized system, and some kind of the authority and kind of a government agency, they only can make some kind of anonymization. It's kind of pseudonymization, and then they can see and link the data, hold the data. And the researchers and individual persons where the industry can access the anonymized linked data, we can see only. But it's a very limited things, and it's the starting time, so we need more conversation or more discussion on that things. Okay. Yeah, maybe there is one more comment.
Oh, let me just back up. I mean, basically, they count any individual data with one patient, they will censor, and that will not be provided. So basically, it's the administrative agency who release the data to the researcher. They count on the numbers. So regardless of the disease or condition, they are a single patient with specific cell. Simply, they do not provide. But as Professor Choi mentioned, if it is collaborative research with the government, under the condition that it will not be released, they will check to the research, and only the government will use the evidence. So that's the situation. And plus also there is special agency linking the data set. They do not get any sensitive health data. What they get is only the administrative information like a birth date and name, and they link, and the link that anonymized data is given to both agencies so that they can link. But they don't have any authority to see the actual content. So that's how the Korean system linking.
Thank you.
Anyone else?
Let Mr. Khachon share a bit more of the Thailand experience as well
Yeah.
in terms of the authority of pseudominization.
Due to SO collect the claim medical data from nationwide hospital. The data we have, we also let researcher or university to access our data to utilize them. To protect this data, we using mixed method, including anonymization, pseudonymization, and generalization. For identity data such as citizen ID, we are using hashing algorithm. So it is one way hash. So researcher don't know who is the patient. And for the generalization, we drop or reduce the detail of data. For example, date of birth, we don't tell date of birth, but we show only year and month. And age, we also grouping. So we don't show the age in year, but we classification in age band or age group. Moreover, for about the disease, although we collect the ICD-10 data, but in the data lake that we allow researcher to access, we reduce the detail. We substring the sorry for the technical term. We substring the ICD-10 code into 3 digits, or sometimes we categorize them into the ICD-10 block or chapter that to protect the privacy of the individual data. Yeah, that is the practice from SO.
Thank you, Mr. Khachon. Any more questions from the room? Yes, we have that.
Yes, thank you. About data security in general, we're talking also about AI at the same time. Isn't AI going to outrun us on data security issues? Aren't we going to face at some point a situation where all the data security systems that you set up are outsmarted by AI, and that we're kind of having a hard time to bring it all back? I was just wondering.
Anyone want to? Okay, yes.
We have a procedure we call data protection impact assessment, and every data system we need to do that. And if we do that, we know who can access the data and what kind of level of access they should have, and including AI. So AI should go through the PIA, so that we will know what they are going to access. Okay. So we are not going to put them into data center and let them access everything they can access. So we have to do it before we put AI into our data center. Because if they can do everything in data center, then we are not knowing what are they doing. That's why OpenAI is so slow, because they have to do this kind of risk assessment and then risk mitigation before we implementing it in the real world situation.
Thank you. Anyone else want to share the perspective on that question? Okay.
Yeah, just to add on what Doctor said. In Thailand, we also have something called as CERT, Thai CERT. It's by NCSA. So everything is effectively monitored, including government organization and data optimization as well. And we have the EU complement of GDPR. It's called as PDPA. So we have Personal Data Protection Act as well. So all the organizations have to undergo through that. And it have certain clauses which cover the AI perspective as well. And if we go to the Thai CERT route, it has something called a sectoral CERT, where they cover all the industries and aspects, including healthcare.
Right. Yes.
Can we train AI to understand and respect PDPA law in Thailand? And can we test them that they really understand and respect to to the PDPA law?
It depends on our policies, but potentially maybe one day in the coming 3-4 years, there might be something related to that because we are currently, in terms of sectorial cert or Thai cert, we are currently ranking number 6 in ASEAN, and we are actually not ranking very bad globally as well. So effectively, with the new AI tools coming up, maybe there might be a day where we would do that.
Thank you very much. We have about a couple of minutes. Anyone want to ask any question before we move on to the second theme? You? Okay.
I think both the speakers, the scenarios that you conveyed involve secondary use of data. So could you also just quickly highlight about the consent mechanism? Consent of the persons whose data was used for secondary purposes, other than the purpose for which the data was collected.
Yeah, thank you for the question. And actually, the secondary use of data is recently we really need more and more data for the research. So actually these kinds of database were firstly captured and collected from the purpose of the review and the claims. But we the researchers and many public sectors really want to use the big data. So that's why we are using the secondary data. And to yes, kind of comment. Thank you.
So for us at NHSO, we are actually not only handling secondary, but we are also handling primary data because we are associated with the government directly, and majority of the primary data includes and since we have a universal healthcare scheme where all Thais are inclusive in it, so we do have records of your ID card number, your age, date of birth, and so on. By the consent-related data or secondary data is related to insurance claims and companies which are registered through us, which is registered through Pakan Sankom or SSF. So those are consent-related data, but we follow the Legal Data Protection Acts in that, which is as I mentioned earlier, PDPA. So we do that.
Thank you very much. Yeah, I think it's about time, and we have learned so much. Even I'm from Thailand, but so many things that I haven't learned yet. But just for today, Professor, can we have microphone for the back?
I want to just point out that a lot of those data protection laws governing the domestic, the privacies, but in the era of AI, when we train the AI, actually it's open to the internet. Anybody in the world can access they may just thought they are anonymized and they put their sensitive information, and all the data is used for train their AI engine freely available. So actually what we are thinking is only the government regulated data protection. On the other end, actually individually, we are sending a lot of information across the border. For example, the government side, GDPR protects the European citizens, the sensitive information cannot go over the border outside of the European Union. On the other hand, all the other people without AI engine, they just input voluntarily their sensitive data. It just cross the border so easily. Or just other medical devices like a continuous blood glucose monitoring device. All those data go into the central server of the company, but it's voluntarily agreed. So a lot of people more care about the privacy issue inside the domestic setting, but in the era of AI, actually individually, we have to educate to protect data. Otherwise, it's just, there are big hole in the data protection.
Thank you. Yeah, I do agree with that too. Yes, before we move on to the next next theme, just want to remind you as well, if you miss the chance of asking question for this time, you can leave your question at the back of the room there. After the break, we can also revisit during the discussion panel as well. But do not ask the speakers' numbers. Thank you. But yeah, let's move on to the second theme of today's discussion. It would be about the regulatory framework, as we have touched on this a little bit on the law and PDPA or etc. But to navigate this critical area, so we have here Dr. Patricia Michelle from the CEO of the Health Enabled and a pioneer in digital health and AI implementation. Please, everyone, welcome Dr. Michelle.
Before I get started, sitting is the new smoking, so if you'll do me a favor and stand up with me. Just reach up to the sky. To the sky. Now to your left. Good job. To your right. Nice. Back to the middle. And then I learned this like really handy neck roll recently. So if you turn your head to your right, roll your chin down, up, and then up to the left, and then come back to the middle. Then look to your left, and then roll your chin down all the way and back. And then roll your shoulders back, roll your shoulders forward, shake it out. Okay, we're good. Okay, so thank you. So I was asked to give sort of a bit of an overview on the state of digital health and AI readiness across different countries using the data from the Global Digital Health Monitor. If you go to the next slide. Before I do that, just really quickly on Health Enabled and who we are and what we do. We're a nonprofit initiative that came out of the mHealth Alliance. When mHealth became a fait accompli, we were doing it. Nobody was sort of asking whether or not to do it. And then mHealth and eHealth were converging to form the field of digital health. So a lot of our work is really focused on thought leadership and charting new areas of investigation, working on national and organizational digital health strategies and policies, building global goods, including the Global Digital Health Monitor, and then doing large-scale effectiveness studies and evaluating the impact of digital health on health outcomes, including health equity. If you go to the next slide. And so the Global Digital Health Monitor and the State of Digital Health Report are a global public good. They're really meant to help raise the bar on the field of digital health by helping countries to really understand and measure where they are in terms of the different enablers of digital health. And it uses the WHO ITU eHealth Strategy Toolkit as the underlying framework. You go to the next slide. So in 2023, we had 23 participating countries, many of which are in the Africa region, and largely through the support of Global Fund to mobilize country participation. You go to the next slide. And so what I wanted to share is some of the analyses from the State of Digital Health report that are relevant for this particular conversation. And if you look at the number of countries that have that are AI ready, that have national strategies or policies related to AI and emerging technologies, very, very few. A lot of countries have, or increasing number of countries, I should say, have national strategies for AI. But a lot of those strategies will specify health as a priority area, but they do not actually specify what within health and or how will health be different than any other area in terms of engagement. We also, included in the last iteration of the monitor a couple of questions on the equity and human rights aspects, and really looking at the ways in which the national digital health strategies and policies explore and include equity, including gender. And what we are finding is that it's a bit of a mixed bag, but very few countries are in the highest levels of really including considerations for equity and or gender in their national digital health strategies, policies, and activities. This has implications for AI, which I'll talk about in a minute. In terms of strategy and investment, we are seeing that a lot of countries do have national digital health strategies or frameworks. Many countries are on there, even on their second and or third iteration. But what we don't have a significant amount of is private sector and or the appropriate levels of regulation and or engagement for the private sector to be engaging in digital health. And again, with the sort of rapid uptake of AI, particularly in the private sector, and then in relation to the public sector, there's sort of a clash that's coming in this particular area. If you go to the next slide. In the area of policy, legislation, and compliance, I was really glad that the first two speakers, talked about security and privacy, including, how do we handle and deal with personal data. What we see is that a lot of countries are generally pretty good in these two areas. A little bit better in the security side, and that's largely because it's the ministries of ICT that do the cybersecurity legislation, but a little bit more behind in terms of the privacy aspects. In terms of regulations for and protocols for regulating medical devices, applications, etc., we do see that a lot of countries are quite behind, that there isn't very strong regulation on medical devices across countries, and that increasingly with the embedding of AI in medical devices, it's going to become even harder to really detect and understand what's happening from a risk perspective in terms of human health. And so something to pay attention to. And then somebody mentioned earlier the cross-border aspects. There are not a lot of really good and strong cross-border policies on data sharing and or data exchange. Again, another consideration when looking at AI and the rapid uptake of AI across different settings. You go to the next slide. So I wanted to talk a little bit about some of the different dimensions of equity, and probably one of the most prominent dimensions of equity that we are seeing across settings is the gender digital divide and the absence of women, particularly in clinical trials, that are being used to train AI models, et cetera, and or that are used to establish health protocols. We have a situation in the United States where clinical trials for heart risk were used to develop the standard protocols for heart risk detection, and these were largely developed on research studies with majority male individuals. And so we have a lot more women coming in at much later stages of heart disease because they do not fit the same profile as men. And so these are just some of the things that we need to be taking into account. In addition, because a lot of somebody mentioned the internet, because the internet is largely, and I will say this, sexist and racist, we are seeing higher risk of areas like technology-facilitated violence against women and girls, and these also need to be accounted for and taken into consideration when we are looking at AI. If you go to the next slide, we also know from a gender perspective that, from a research perspective, that when gender is taken into account in the design and implementation of digital health interventions, that the outcomes are different. And so what we're finding is that outcomes are generally positive for different digital health interventions when they're applied to proven health, known health interventions, but that they are even better when you do take into account a gender intentional lens. You go to the next slide. So what we're seeing is that there are multiple divides that are now impacting digital health and AI across different settings. And one of the most challenging ones, I would say, is probably the fact that in terms of representation, that Sub-Saharan Africa is very much at risk at being left behind. We're also seeing that a lot of countries that are not engaging in their own clinical trials are also being left behind in some of the AI work. And so really trying to think about how do we approach these different aspects of AI with more of a pro-equity lens to make sure that the data that is being used is representative of the populations that we're trying to serve, and that the algorithms have some level of transparency and governance that engages and has strong representation across the different groups that will be impacted by those algorithms. If you go to the next slide. So really quickly, around equity, equity is really about everyone having the same ability to and opportunity to have full health and well-being, to have their best health and to have the best well-being. And I think we need to take that into account when we are looking at AI. I sit in many AI conversations, and everybody gets so enthusiastic and excited when their AI algorithm is accurate. And I'm like, great, good job. I'm glad you got the algorithm to do the thing that you wanted it to do. But will it really make a difference in people's lives if we don't account for the people who we actually want to help improve their health and well-being? And so I think we need to take a much better look at equity when we are engaging in these various AI conversations and discussions. If you go to the next slide. It needs to look at data equity. So, where and how is data coming from and being used? And then if you go to the next slide. And then it also has to be accounted for in the large language models. There's some work that has been done to develop metrics to measure health equity in large language models, and I think this is a really important toolbox to take a look at. And in addition, some of the work around the health data governance that, in addition to really ensuring equity in algorithms, we need to really ensure equity in data. If you go to the next slide. And so just some thoughts around, this movement that we are all on. I think sometimes we do have to slow down a little bit and really make sure that the data sets are inclusive and diverse, that we are regularly auditing and reviewing biases in algorithms, that we are, measuring fairness, and that we are establishing guidelines for the ethical collection and use of data. You go to the next slide. And that is all I have to say. So thank you.
Thank you very much, Dr. Michelle. Yeah, I really like your presentation, actually. Just we need to realize that technology can bring us closer, but it can also widen the gap. And the fact that she's mentioning about equity is very important when it comes to AI adoption and implementation in our society. Now is the time for the Q&A for this theme, but I like to take the liberty to ask the first question, if you allow. And then you guys can think of more questions to ask our speakers as well. I think you briefly mentioned about the gender equity. When we incorporate that gender lens into it, then your research informed that it leads to perhaps different outcomes. And are there any particular reason or explanation to this observation in this case? Yeah.
Sure. So one example, so the study that we did in Pakistan on the use of an electronic immunization registry, what we found was that the application was meant to be used largely by male vaccinators, going to households and asking, female caregivers to give them their phone numbers, and so and of course, a lot of, women would refuse to give their phone numbers to a strange man that knocks on their door to come and offer vaccination services to. It's more about being culturally, sensitive and appropriate than anything else, that we need to really take into account, the way in which individuals live and engage in the world. What we also find is that a lot of, and it's so interesting because I grew up, my family's originally from Egypt, and both of my parents are computer programmers. And so I never saw a difference in terms of gender and technology until I was much older. And I did public health, and then I did a PhD on mobile phones and health. And then I got into the tech sector, and then I was like, oh my gosh, there's no women. Where are all the women? And so a lot of technology is designed by men, not designed by women, and not including women as part of the design process. When my parents talk about their approaches to computer programming, my father will say, I would come up with a solution. It's like your mother would come up with the most elegant solution. And so it was, I think we are different. And I think we bring different things into the way that we approach, whether it's technology development and design, policy making, as well as navigating day-to-day life and our interactions with technology. And I don't think we do enough to take those things into account when we are engaging in design, development, policies in this particular area.
Thank you.
Thanks, Patty. I really appreciate it. Nice to see you again. Really appreciate the presentation. I was hoping to ask, I really appreciate the focus on equity and artificial intelligence. I was hoping to go back to AI readiness, and was hoping to hear a little bit more of what that looks like. How do you increase AI readiness from a kind of governance level, and how would that what would be your vision for an equity focused readiness for countries? Thanks.
So a lot of times, AI strategies and policies will focus on the things that like AI will not do, rather than charting out like a real vision for AI. And I have to say, I appreciated the keynote this morning because it was like, okay, we can use AI for these specific things. And I think for countries, I think it's really important for them to identify kind of like where they see themselves in terms of, and where AI can be contextualized to their specific kind of country needs, instead of this sort of, right now, everybody just sort of like throwing, everything out there in terms of like AI for everything. And I think we need to be a lot more focused on where AI can really add benefit and for whom it can add benefit, and then to make sure that when we are looking at the for whom it can have benefit, that we're being inclusive and we're accounting for their engagement as part of, and representation as part of those processes. But we're not really seeing a lot of that. I think a lot of what we are seeing is just very high level, very general, and not particularly kind of well thought through, because AI is expensive. It's not cheap, and it's having negative effects on the environment with all of the compute that's needed. And I think we need to take a breath and really become a lot more, kind of like strategic and thoughtful about where we feel like the differences can be made, instead of just trying to see like what might rise to the top in this area.
Right. Any more question? Yes.
Thank you. I have a question from the professor from Korea about the patient identification number. We have the same patient identification number, which is a great advantage for digital health, but then also that's similar because we have the date of birth inside it and then the region of the birth also here. So lately we have concern about that information included in the identification number. And then there are even discussion about assigning different identification numbers to the patients as well. I was curious about the situation in Korea. Is there any concern about using such number, including some sensitive information in it?
Okay, thank you for the important question. Actually, in the Korea, we randomly put the numbers to which we change the sensitive in identification number to the random number. So usually the researchers cannot link again to the whole data again. So it's a wholly different and the new number. So we cannot identify the individuals again, but the authority sometimes, it's not usually, before the amendment, we cannot re-link or re-identify the database for the research purpose, and we cannot re-link the whole database again. But recently, from the amendment, that can be linked again, because we need to link more data for the hospital data or the other organization data with the government data sets. So it's kind of tricky, but the pseudo-anonymized data, they can be linked. But there is a really strict and some kind of conditions they can do that again. So yeah, that there is it's under the discussions is under processing now. So yeah, okay.
Thank you. Any more questions? Yes.
Okay, make a quick comment regarding the question from Zoe. Like, I think there was this trend of having, the province, related data or the date of birth or their gender in the national ID used to be there. But if you see in the later generations of countries issuing the national IDs, I think it's morely random number. For example, in India, it's a random number with 12 digits. So there is no other identifiable information in that. Thank you.
All right. Thank you, everyone, for coming back to the room to continue our conversation on this AI implementation and challenges in different contexts. Next is the third theme of today's session. It's about economic and infrastructure challenges, which we have here with us. Our speaker is Prof. Peeter Rose. So from Tallinn University in Estonia. Yeah. So without further ado, let's welcome Prof. Rose to share with us these insights. Thank you.
Thank you very much, and good afternoon. And thank you for this kind invitation also. Actually, I will continue from where Dr. Choi and Patty ended. I will talk quite a lot about ID, unique ID, and also that we have to use AI for specific goals, not just think and wait that AI will do something. I'm a radiologist by background. I'm a professor of e-health in Tallinn University of Technology. And in this session, I have to discuss about economic and infrastructure challenges. And I will do this based on Estonian experience. Being a radiologist, and actually it's my 30 year in radiology. When I graduated, actually 30 years ago, what do you think what I was told? I was told that it's not wise specialty to choose because computer will take over your work soon. 10 years ago, Google said that stop training radiology residents because computer will take over. Today we hear AI, but believe me, there hasn't been a consecutive year where I have less work than previous year. So, and this shows very clearly that algorithms as such are not the solution. The solution is how to integrate these algorithms in the workflows, in the patient pathways, and so on. Because 30 years ago, there were algorithms which were much more precise than human eye. And they are there still. So why they haven't taken over? Because this is only a fraction of the radiologist work. Right. Then I will start with looking the global situation of digital health maturity. This is a study from EMEA. So this slides now advancing by themselves, so I have to hurry up. On the horizontal axis, there is GDP per capita, and on vertical axis, there is digital health maturity. And as you see, then there are some leading countries, and they tend to be in the right side, meaning that the GDP per capita is quite high. Estonia ranks also high, you see on the left upper side, but we have done this like 3 times less resources than others, then maybe that's the reason why I have to talk here today about economic background of digital health. I think it's important also to look what was the methodology based on what this benchmarking has been done. And you see there are 12 elements. They are grouped into 3 bigger groups, which are like initiatives, policy, infrastructure, and then applications or implementation. And as you see then, actually artificial intelligence here is only one part of the whole process. So we have to understand that we shouldn't talk only about the button, but also about the jacket, maybe. Meaning that the AI should be really used in a way that it will help our work, not opposite. This is, of course, after a Korean and Thailand introduction, I should to have a compulsory slide of Estonian geography and background. So we are in North-East Europe, part of EU. We have a unique ID, similarly to Thailand and Korea. And then we like to claim that Estonia is the world leader in unicorns per capita. And also we have quite unique feature that you can have an Estonian e-residency. When we talk about digital health or large-scale digital health implementations, then it's worth, of course, to think and talk about the e-government setup. And in Estonia, where the only thing what you can't do online is marriage. You have to see your bride. But all other services you can do online. Then also digitalization of healthcare is much easier. So as you see, most services are online. Estonia has this unique feature that we can vote online. This is still one and only country in the world where you can vote local government or EU elections online. It's quite convenient. You know, you sit on couch and just decide. And then we have these e-residents, which is the opportunity to any one of you to start to use Estonian digital services. Again, one thing what you can't have is citizenship. Now I will discuss a bit about the importance of unique ID. We heard already from Dr. Choi the concept of it. In Estonian case, we have 11 digits compared to Korea, where you had 13. And it's compulsory. And what is also important that this ID is linked to the digital identity, meaning that when the child is born or if a person gets Estonian residency, he or she gets also digital identity. So all the services are linked to then this identity. From the architecture-wise, we are using a secure internet-based data exchange layer, and we call this X-Road. And X-Road is it's not the road as such. It's a data exchange layer. So what's the traffic there? It is exchange of messages. secure environment where you can exchange messages. And our government, and this was more than 20 years ago, decided that once we don't have enough resources, we shouldn't duplicate. So we have to keep data there where it is generated. So this was one concept. And as you see, then there are different databases, either public or private, which could be accessed then using this secure identification by any person in Estonia. And each database has its adapter server and security server. I'm very sorry, the slides are advancing by themselves. But yes, so there were two important decisions by the government. One is that the data should stay where it's generated, and the other is that each resident of the country will have a unique ID with digital identity to use these databases if they are entitled to do so. So no gender differences. And what is, to sum up, what is the beauty of this kind of distributed architecture is that definitely it's secure, it provides confidentiality, it avoids uncontrolled centralization, which is also very important, not to have big central databases. Then there is a so-called one single source of truth. So, for instance, person data is always in the population registry, and you don't need to duplicate it anywhere else. And it distributes power of information ownership, and it is using kind of blockchain to track all the traffic. Then let's move to the healthcare. We have a very similar healthcare setup as Thailand and Korea. We have universal health coverage. What is important that our GDP share makes up to 7.5% of for health spending, which is much lower than in OECD. It's a little bit higher than in Thailand, but I like to claim that this is because of the digitalization, of course. And talking about the Estonian health information system, then it really covers all country, including, of course, claims management, but also medical data. Includes all residents, and it's based on this nationwide e-government or e-state architecture. I, as a radiologist, I haven't used pen and paper maybe 10 years. So most data is digital, but still in hospitals we do have paper for the nurses' notes and, for instance, for intensive care unit sheets. But gradually they are also moving in digital mode. And this is then health architecture. And what is, as you can see that it follows the concept of e-state architecture, that we have here data providers, different hospital information systems, pharmacists, GPs, dental care. Then we have these auxiliary services, and then we have central databases here in right lower corner. What I would like to emphasize here is that these green boxes, these are standards. So again, if you would like to implement different AI methods, we need to have high quality data. And for high quality data, we have to follow terminology, standards, classifiers, and also data exchange standards. Then what is beneficial of this kind of distributed system, that we can apply central services. And here are two examples of centrally applied digital decision support systems. One is for GPs and other for any doctor for drug-drug interaction notice. These are very common services worldwide for last maybe 10 to 20 years. But the difference of Estonia is that these services are applied for the whole country. So it doesn't matter where your prescription is prescribed, all the data is taken into account. And I will give you an example of this drug-drug interaction database, how it works. Drug-drug interaction database is the software what alerts when two medications are prescribed which are not belonging together. And in the Estonian case, this is off-the-shelf product. When I prescribe, then there will be first query from electronic medical record goes to the prescription center where all prescriptions are. If there is no prescription, then I'm free to prescribe. If there is prescription, then new prescription with the current medication is sent to the drug-drug interaction database, and then I will get alert if there is a contraindication to prescribe. We have done some research how much alerts there are, and you can't believe the number. There are 10,000s of day. And this, of course, these are not all serious interactions, but like a notices or. But this shows how important it is to use common infrastructure, integrated data, to improve the care quality. Imagine how many lives potentially have been saved because doctors haven't not prescribed wrong medications. So what there is in our system, there are different documents, digital documents. There are also services like e-prescription, e-referral, e-ambulance. We talked about drug-drug interaction service, nationwide picture archiving and communication system, and so on and so forth. Concerning e-prescription, again, Estonia, we don't have paper prescriptions. There is zero paper prescription. And then we have these cross-sectoral services like you can apply health declaration for driver's license without seeing anyone do this online. If you are ill, your information about working incapacity goes again automatically to the insurance and so on. And now in Europe we also have a chance to start with cross-border services. So like with the e-prescription, Estonia, Finland, Poland, Portugal, many other countries have already opportunity to buy prescriptions from other countries. And work with the patient summary is in progress. It's not in so many countries yet. These examples I brought them to show that we have to aspire to the situation where we don't duplicate, where we use the existing infrastructure both for identification, linking person for different purposes. What are the next steps in Estonian case? I think it's really worth to emphasize once more that today more than ever the IT concept that trash in, trash out applies. The myth about AI which will solve all problems, believe me, it's myth. And we have seen this, that we have to pay a lot of attention on the terminologies, on the data quality. And therefore, we have starting to look at the decision support systems for data entering, not using the data, but how to enter the data, how to convert the free text right away into SNOMED or other terminologies. Analytics now could be much more used for the care quality and performance analysis. What is trend definitely is to include also health data. When I talked about Estonian e-health system, then it was actually Estonian disease system. Because most of the data is coming from the hospitals. But if you look the amount of data what we collect through the activity monitors, different gadgets, mobiles, then this is health data. This is what we should use in the future much more to prevent the situation when people get sick and have to go to see a doctor. Self-reported data is another topic what we see will increase, and consent engine for users. When we had discussion in the previous first part of this session, we had discussion about the data security and privacy, and it's clear trend that governments try to regulate it. But we can think also opposite, that actually I as a person should regulate it. So I should give consent who and when can use this data. So this is what we have also in Estonia designed for this X-road. And this is not only for medical data, this is to any data. And this is in line with GDPR also very a lot. And finally then development of cross-sectional services, integration of social and healthcare services, and creation of real digital health market which will cross borders, maybe also continents. And this is to sum up. This applies to the knowledge we have gathered when we implemented the Estonian digital health system. I added here actually 10th command yesterday, which is definitely very important. But I think this applies very much to development and use of AI as well. So we have to have a vision, strategy. We have, of course, have computerization, financing, but also clear governance, legal clarity, use already existing ecosystems, do this securely with established online identification methods. Capacity building is extremely important. I have been maybe in 20 countries or so consulting large-scale implementations, and if there is no human capacity, there is no result. Accession rights, and finally, last but not least, standardization. This was a brief overview of the use of public infrastructure for digital health and also for some new services. Do this as economically and as affordable as possible. This was Estonian case. Each country has its own case. There is no one size fits for all, but probably there is now enough material to discuss further on. Thank you.
Thank you very much, Prof. Ross. Now it's the time for the question. Any question for Prof. Ross before we go to the next session? Any question? You just learned about becoming an e-citizen of Estonia.
Just to get started, so thank you again, Professor Ross, for sharing Estonia's experience. We've heard so much, it's almost mythical, so thank you for making it a reality for us. Would just like to ask a bit, you showed us the system that you have in Estonia, it seems amazing. How much did this cost? Who paid for this? And was Estonia always able to manage this? There's many of the countries represented here, also middle-income countries. Is this something that we can also aspire to, or it's something we should plan for in the future?
Thanks, very good question. You had this 30-path project, yes? Yeah.
Yes,
so yes, you have to know how much something costs. I have quite exact figure about digital health for a certain period, and we summed it up. So we started planning of digital health platform in 2005, and it went into live at the end of 2008. And then we calculated costs between 2005 and 11, and it was, I still remember it precisely, 9.2 euros per capita. So you can start collecting. So it's compared to like, even if you look at these global electronic medical record providers, it's like maybe 10 times less if you compare to this. But it's because of probably because of using these e-government already established security, data exchange, other tools.
Any more questions? Yes.
Hi. So actually, my question was also something in line with what she asked. My question is more on the data exchange layer. So I realized that a common theme in the structures is that there is that X root, that data exchange layer, which is the secure exchange for information, which guarantees the confidentiality of the. Oh yes.
Fully guaranteed.
Yeah. Like just curious. Like around how much is it, and also curious how you got the corporate companies, like convincing them to want to join this, because I think that's a challenge also, right? Yeah.
Yeah, very correct observation that it's really the question is who will use it, because it's an enterprise bus actually. It's nothing special. And the answer is that you have to create services. People are interested about services. And in Estonian case, it was a tax refund. Today I get tax declaration done in 3 minutes and get money back in 2 days in my bank account. And when this was implemented, people are started to ask, okay, why should I go to, let's say, to the land registry and have some paper? Let's have this service also in X-Road. And so we got critical mass of services. And this was the crowd who said that we We don't want to have paper. It wasn't government who somehow obliged people to do this. So find the silver bullet. What is the service which really people want to use? In digital health it was e-prescription in an Estonian case. When e-prescription started to work, then there was full trust, and gradually, as you saw, e-referrals, e-consultation, everything took off.
Thank you.
Perhaps there's one last question before, then the next, yes.
Hello. Does Estonia support open source in the development of its healthcare system as a state policy?
Thanks. Yes, very good question. X-Road itself is open source. It's then we use all, well, not maybe all, but we use open standards like HL7 or international standards. But when it comes to joining the maybe this ecosystem, then it's open, but it's not easy, and it's not easy because these factors, what we actually heard also from Thailand and Korea, that still government wants to control who joins, who gets the data, who provides the services, but by default it's open source, yes. By default, but in reality there are several like barriers to join there. Thanks.
Right. Thank you very much, Prof. Ross, and also all the participants here for sharing your perspective and also question too. Now we have completed all three themes. Still, the whiteboard is remain at the back of the room. If you have any further questions, please feel free to leave them there. And before we start to the next session on panelist discussion, just want to share as well, if anyone here would like to have the presentation that our speaker just presented, please feel free to leave your email address with the registration at the front of the room. Our speaker has kindly agreed to share. Yeah. The next, to conclude today's session, we have about an hour or less than that session discussion, which will be moderated by Mr. Mark Landry, a program officer at the World Health Organization. Mr. Landry specializes in digital health and health system strengthening, making him an ideal person to guide us in this discussion panel. Please welcome Mr. Landry, please.
Great, thank you so much. Can I invite all the speakers back up, Surakamhet included? And we have a new face that's going to join, Jay Ganesh, as a discussant. Many people might know him already, so we're glad that he could join. He's the executive director for AHIN. So what we want to do, if I can sit here, thanks. What we want to do now is try to bring this together. The hypothesis is AI a panacea for the health sector? Is it a resounding yes? I think it's a no. But we want to look at this in maybe a more holistic way. We are at the end of 2 days of side meetings. And I think many of you have been in other sessions, have had opportunities to look at other dimensions. So remember, for this particular side meeting, we're looking at the cybersecurity, equity, regulatory frameworks, and the infrastructure, the digital public infrastructure. And we saw a great example from Estonia. But there are bits of other pieces that we've heard from other discussions throughout the last 2 days, particularly around the patient provider workflows. In a session, I think, Peter, you were in yesterday, I think Bilal Mateen said, let's see how AI can do the boring things, right? To create efficiencies and other things. There's a lot around capacity and education, governance. So that might bleed into this discussion, but what I wanted to do is just begin to try to integrate and think about some of this in a more holistic way. So as you're thinking of questions, what I would like to do is I will start to ask our panel, not go down the line, but they know, we'll just make interventions according to their interest in that response. And then you two, please, if you have questions, I'll maybe share one that I have prepared. We'll go to the audience and back and forth, and hopefully have as much of a conversation as we can. So if I may, and again, I appreciate all of the perspectives that we heard. I think it was very rich and dynamic. So, in particular, I think we really want to understand, as I said, that we've heard from these different perspectives, but my first question to the group is, how do you now take forward AI, appropriate use of AI, to support healthcare in low and middle income countries in an integrated way? How do you bring all of this together in your perspective, which would be a very effective approach? So over to anybody who would like to volunteer a response first.
I'm warm. I'm warm already.
He's warmed up, yes.
I can continue. So I would look from the perspective where we have gaps. And we have gaps in workforce. And we have gaps also in maybe data capture. So probably these are the areas where AI has been, actually large language models have shown their strength, using, for instance, collecting patient history by chatbots, for instance, or having some triage before seeing a real medical professional. So these areas where we really lack of resources, but where the AI is good, rather than start with some very sophisticated algorithm to improve treatment of cardiovascular diseases or something.
I love that, and I think I hope this has come through in all of the sessions you've attended the last 2 days. It's not about what AI can do. It's where can AI gap fill or actually eke out greater health systems efficiencies or serve a higher purpose beyond the novelty of the AI and the use of it. Anybody else want to provide? Yes, Surakamhet.
Yes, I'm from, or maybe, yes, Thailand is still in limited resource setting. Okay. So in our perspective, we want something that can do what we could not do without human power. So the chest radiography that I told you, we actually had 10 million a year. And some of them wait for 3 months, 6 months to be read, and then the patient call back and they disappear. Okay, so those are kind of things that we can use AI for helping the shortening of the waiting line. So those are kind of things that we would like to do. And most of them are normal findings, which is fine. And then we would also need to taking care of like classification bias based on AI, right? And that is, I guess we need to have something very innovative, like insurance program for that AI implementation. So if something happening because of we use AI instead of the routine process, we taking care of them. Okay. And then another thing is, oh, I forgot, sorry.
No worries. Anybody else want to tackle this one before we go?
I would also like ask the question of like AI for whom and for what, right? And so I think we're getting closer to the what, but I think we do have to keep paying attention to the for whom and who stands to gain and who stands to lose, and who's included and who do we risk excluding?
So another things that we can use AI for is to improve the quality of care. And if the quality of care is still worse than the standard, the international standard in limited setting, we should look at how to use it. And then another important thing that I took off from your presentation is that we can improve quality of data entry into electronic medical record using AI. And that is something we want to do now, because data quality at the hospital is just 20%, 30%, and it's supposed to be close to 100 now. And that if we implementing AI for auditing that medical records, it can be rapidly improved right away. And we do not have human resource to do that. Yes.
Excellent. So, think of it as minding the can-do gap, but as Patty reflected on, the can-do should gap, right? So prioritizing and identifying those use cases that are, most optimal to be investing in right now for the right time, for the right purpose, for the right intended beneficiary. Okay, over to the audience. Anybody have a question you'd like to ask this very dynamic group?
Hi, my name is Amelia. I'm from Hyper. I like the point where Patricia mentioned who stands to lose from AI. I'm very curious to find out from the panelists. You have mentioned many benefits of AI, but I want to know what do you think about what will happen when AI fails, and whether we are prepared to stomach the cost when actually AI don't go the way that it is planning, like it plans to be. Yes, thank you very much.
Brilliant question. I'm intrigued.
There was a recent review of like 200, health AI claims, and I think out of all 200 health AI claims, like 180 were false. That there is a lot of bluster happening in terms of what people will say that AI can do versus what it is actually capable of doing at this point in time. And so it really is a black box. And I think the risk that we run is trust. And so if we're not careful in terms of how we approach AI and how we engage people in the approach to AI, and how we measure the effectiveness of AI, not just the does it specifically do the one thing that you've like trained it to do, but can it exist in the real world and generate the health outcomes that you're interested in achieving with the populations that you're interested in engaging. This isn't really happening just yet. And the regulation, because the regulation isn't there, nobody's actually really paying attention to what it's doing. And so there's a lot of discussion now around AI snake oil. And I do think we run the risk of losing people.
I think this also leads to a question that yes, like AI could be a tool, like for example, screening when the resources are low. But put yourself in that position that you would like to be diagnosed by AI, given a chance that you want AI to diagnose and decide for you, or you would like to go ahead with a clinician face-to-face. So I think that's also important, that the one who is actually the recipient of care is comfortable to be probably used for this. And then the second one is like, when we talk about AI, how about the data governance? I think most of the countries still do not have a clear-cut policy or regulations related to governance of health data itself. Then comes the AI. So I would say that, I think we should probably also look into that. And then we do have strategies for digital health, strategies for AI. And these are like, probably done kind of more siloed way. Probably there needs to be also an integration. Of course, like it might complicate the matter, but having different strategies, different policies, and especially everything is related to health also complicates the matter. And then the third one is, of course, related to the regulations that recently I also did a quick survey, and then it's not a proper systematic review or something, but it's a quick survey. But again, we are talking about in the context of LMICs. How many LMICs do have regulations with respect to AI? Yes, some of them have started, but it is mostly the G7 countries, EU, US, and then, of course, China and few others. I think Brazil has taken a quick lead on that, but not many still have. So in that context, like allowing that applications to be used in the clinical domain is a risk. Thank you.
Great, thanks for that. And I wanted to maybe build on the point from a different discussion yesterday that was focused on cybersecurity. And the comment that was made was, and it holds here for when AI goes off the rails, right? You can restore the data. Remember this comment, Surakamhet? You can restore the data, or you could revert to a human, encounter and diagnostics, et cetera. But you can't so easily restore the reputation or the trust. It's lost, right? How many times have you gone to an online tool and it just stalls and you don't go back? I mean, if it doesn't work the first time, if you don't get it right the first time, it takes so much more effort to restore that confidence and trust. So building on that, any other comments on that? Because I'm going to build on this if I may, or? Go ahead. Oh, okay. But, again, so, what are tactics that you feel, or even if the audience wants to respond as well, please, to build confidence and to build trust from the public, because we don't have all the guardrails. We don't have, all of the, regulations and the trust from that we expect from government through laws and regulations, et cetera. So in this state of limbo, until we have that more well understood, what do we do? I mean, how do we start to build that trust and rapport with the public? And so I would appreciate some feedback or comments on that. Because I think another way to put it is I heard many discussions the last couple of days. In the absence of doing nothing, is the use of these AI enhanced approaches better than that? Well, of course, in many cases it's better than nothing, but is it still appropriate and ethical, et cetera? So please, any comments from that perspective?
I mean, I think there are growing like fairness metrics. There's growing, other measurements. I think we need greater transparency first. We need to insist on greater transparency. What data, who's engaged, what are the models being trained for and on, and how, and all of that. And I think we need people to also become better, educated, more knowledgeable about from a not just people keep using the terms like digital literacy. I think people need to become more digitally fluent, and I think we need greater AI, fluency among humans to better engage with, okay, how is AI being integrated into everyday life, and how can we engage with it? But as a community, we need to be developing the metrics and the measurements so that we can set the bar for, AI, particularly in the health space, so that it's not just a black box. Yeah.
Excellent, excellent. I think Kun Khachon, you had a comment as well. Now we're doing fireside chat. It feels so cozy now.
Welcome.
Woo! It's getting a little warm in here.
If you want.
Exactly. I was like, AI is in the fire.
Okay. So let me add on more about the public trust and ethical consideration. In my recently presentation, I forgot to show you about the tool that we had invest about the security tool that ensure the, our data privacy and security. I think building public trust in AI for healthcare, we require focus on transparency, ethical consideration, and stakeholder engagement. The first thing to ensure the data privacy and security, we should implement the dynamic anonymization. If we do the simple hashing algorithm or encryption, I think the hacker can decrypt easily, and we need a privileged access management tool for capture or activity that the staff access the data. So we ensure that the data will not leak, as well as the data leak prevention or DLP tool that we install to all client or the laptop of every staff. Moreover, I think engagement in public awareness campaign, we should educate stakeholders, including patient and healthcare provider, on how AI enhance healthcare outcome while maintaining privacy and ethical standards.
Excellent. These are great, not only recommendations, but based on core principles, and I appreciate that perspective as well. Anybody else want to chime in on this point? Yes, Jay?
Recently, the Health AI, the Global Agency for Responsible AI in Healthcare, they approached AHIN. And then they talked about their plans to work with the countries in the region as well, like how they can work with the countries, co-create, and what they are looking is a set of pioneering countries who have plans. They don't have the regulations in place, but they do have plans to work on that. So those countries they want to onboard and then co-create the process, including validation rules, and then also help them get to the regulations. So that's also another opportunity for those countries who are willing to work together where regulations are not yet in place. So from AHIN, like they are keen to brief countries who are interested, and then they said like those ministries of health who are interested in this can actually reach out through AHIN or directly to them. I'm aware that they're already working with a couple of countries in this region, and then they would like to work with more countries. That's what I know. So they had sent us a briefer, which if anyone is interested, I can share, where they have already shared the process of onboarding and what happens. If anyone is willing, that they could talk to them. Thank you.
Great. Thank you. Yes,
yeah,
Peter.
if I may add, my wishes where the life should go. Then today we are using AI, word as AI. But I don't know how many of you knows what is behind of AI. It's for me it sounds like also like medicine will help. Medicine will help us. Okay. Very good, but you have to choose a doctor, specialty, you have to know what is the disease. The same is, I hope that we will explore more what is behind of AI. Behind of AI is large language model, machine learning, deep learning, voice recognition, image recognition. Just name, like in medicine we have ophthalmologists, we have pediatricians. So, and when we understand that each of these methods in AI umbrella is meant for the certain problem, then I think we could start to trust when there is no black box anymore. There is no medicine or something. There is hospital, I will be treated. It's not, we have to find the operating theater or specialists who will treat. So I very much agree that we have to create the more awareness among both in medical stuff, in IT, and with patients in general.
Great, thank you. Back to the audience. We have a question here in the front.
I'm very impressed by Peter Ross's figure of around about €9 per head over almost 10 years, no, 6 years, right? But at that time, there was no AI and no, fancy technologies like we do have today. Today, if we want to invest, if countries want to invest, how much would it cost? And what's the danger that after you invest, then a few years later, another technology which is much superior come along, and then you have to reinvest? So I would like, to have some ideas. Thank you.
That is the most difficult question, but I'll tell you what's happening. What's happening in Thailand, and I can, I'm based in this country. There is a very profound recognition that they need to go back to taking stock, see where AI is being used, right? Do a landscape analysis, understand the gaps, and find, what are opportunities. Part of that can be consideration for the costing and when you think about the transformation of AI, just in the speed, the buzz for 2025 is AI agents. Everybody will have their own AI buddy to do all of their mundane work for them, and this will be the new AI shiny thing. So you can never keep up with the disruption and the transformation. But I think what is happening in Thailand is this real need to find out what's happening now, what are the best high potential use cases, where can it be done quick and efficiently and move forward. But there's still some discovery to be done to see what would be the way to go about that. So I think that's a fair approach. Take stock and try to plan and take a do it right, not rushed way forward. And because I'm saying anything about Thailand, I have to go to the Ministry of Health for a counterpoint.
I just want to respond to him because the question is like shocking for us, because the technology is coming like every 3 months, 6 months, and it seems to do anything we can do, right? And I think the answer will be we just need to focus on people who understand the technology, to have those people to judge when we should invest. And that is something Thailand did, I think. We have AI strategy, and we plan to have 30,000 people in AI, and about like 500 a year expert, so that they can just they can help us judge what to invest and which one. So we are not going to make new LMM, similar to China or US, but we need to know which one is the best for us at the right moment. And those people will help us do that. Not me at the moment. But
great. Anybody else want to tackle that question? Is your €9 going to cover that or not, Peter? Okay. There was one other one I wanted to bring up now. So back to some of the boring things. So what do you see in terms as an enabler? In what ways can AI, complement these systematic reforms, workforce readiness, traditional healthcare systems, et cetera, rather than just being seen as a replacement for human actions, right? So, where do you see this technology really helping to, create a new way of working that might be not only new, but also appropriate, safe, secure, all of the guardrails that Patty, you brought up. So again, in what ways can AI complement systematic reforms, workforce readiness, and traditional healthcare systems, rather than just being seen as a replacement for human expertise? And I'd like to hear from Korea. Dr. Choi.
Yeah, I'm thinking that one major challenge in the AI-driven healthcare is the data bias, I think. So particularly when the certain populations are underrepresented or missing from the database. Even in South Korea, where universal healthcare coverage exists, and some individuals, despite having insurance, they may not seek the medical care due to the factor of financial burdens or accessibility issues or the social stigma. So if these groups are not adequately reflected in healthcare data, and AI models may fail to address their needs. So to ensure equitable AI, we need to inclusive data collections and regular bias audits and transparent AI decision-making to prevent unintended discrimination and ensure the fair access to healthcare for all. Yeah.
I appreciate you bringing that in at this point even. This is great. Again, it brings on new challenges to think about uncoupling what are inherent biases because of the data that is being fed into these systems. So, these are human expertise that need to be built to be able to, also keep AI, in check. And so I appreciate that perspective as well. Thank you for that. Any other points about, is AI going to replace human expertise in terms of the health system strengthening when way forward?
Yeah, one more thing I'd like to mention. And actually, I heard about the drug-drug interaction from the Estonia. It was started from check from the prescription. You check your system, check the drug-drug interaction from the 2016 maybe in your slide. But in Korea, actually, we introduced that kind of system from the 2008. It's quite a long time ago. But we made some kind of algorithm on the population system. And when some doctor prescribed something, and they check their medical record from the other side, and they check the drug-drug interaction to the doctors to send the information. So these kind of things already exist from this kind of recent population setting, but sometimes too much alarm to send to the doctors or pharmacists. So in that case, they ignore the alarms usually. And sometimes the AI is very helpful, but sometimes the other side, the people don't want to listen too much alarm from the AI. So I think in this here, we need to found more accurate information from the AI system. Yeah, that's really important.
Thank you. So proceed with caution is the message there.
I mean, I do think there are, certain areas where we are seeing really good promise in terms of AI. I think in the field of like mental health, I think there are some really and mental health was probably one of the earliest areas where even digital health and mobile health before AI came in, was showing to have really positive effects because people, don't feel as comfortable sitting in front of a psychotherapist as they do, in the anonymity of their home, interacting with a chatbot that can ask them
kind of like how they're feeling. And so I do think that there are going to be applications or ways in which AI, particularly in low middle income countries where there are certain specialties that we just don't have enough of. So like dermatology, ophthalmology, there are certain areas of health where I do feel like based on, you know, a history of telemedicine, et cetera, where AI can, you know, if done right and introduced in the right way, could actually play a really good role. But we do have to, you know, be caution as to like, where are the algorithms being trained? What data is it and being trained on? You know, we've seen in dermatology, you know, African skin, not necessarily, you know, skin conditions on darker skin, not easily detectable. But, you know, there are efforts by African physicians now to set up databases that are, you know, reflective of the populations so that, you know, these algorithms can also be trained on that sort of data. So I think it's going to be the gaps. It's going to be where are the gaps, but then also where are we seeing, you know, key areas that we with a certain level of confidence can say, okay, that's working.
Agreed, totally. And so if not a panacea, I think we're all converging. With due respect to Ahin, we're converging as AI as an enabler. I think that's very clear. There's very clear examples where we're on the right track. We're seeing excellent results, but there is always the fact, you know, we don't know what we don't know, and it's coming. Anything else on this point? I'm going to ask for one more from the audience, and then we're going to do a lightning round of quick feedback from the panelists and wrap up. You had one comment first.
The one question that regularly keeps coming up is like, we used to talk about the clinical decision support, right? CDSS, very famous. And then now AI. A lot of people keep asking what exactly is the difference. So maybe if I am allowed to ask this question to the panelist, maybe to Dr. Surakamhet as well as to Peeter, being a radiologist. The difference between CDS and AI. Yes. AI could be part of CDSS, right? Why now no more CDSS? Everybody's talking about AI in healthcare.
I think it's in the detail. Maybe something that Professor Peeter has already told us. In the old days, rule-based thing. So we have the like a decision that we already made for the, I mean, clinical practice guideline, something like if you have chest pain, you have to do electronic EKG, and then if it is abnormal, you go somewhere. But that rule-based thing is very restricted, and people do not do things based on the rule-based thing. We have a lot more things that we didn't written in the guideline that we use to make decision. And right now it's become LMM, and LMM use everything. It is multimodal things, like we use image, audio, EKG, and it may capture many more things in the future. And if we use everything that we use, then we will come close to the human decision. And that is make the difference. So if we are talking about our sense that we have, and they can make a objective decision without personal bias, they may be a little bit better than us. I mean, in terms of expert. In the junior, they already better than us. Like compared to the junior staff, they usually think better than our junior staff. So they can help our junior staff. That's my answer. Thank you.
You want to weigh in on that one, Peter?
Do you want to honest or scientific answer? Honest answer is AI is easier pronounced than CDSS. But yeah, I think you explained very well that it's a different application of rules and math. So it's there is no actually like a fundamental difference. It's a tool that helps to structure human thinking. at the end of the day, I have to make decision anyway. But then, like in radiology, why this has taken so long time? Because the computer-aided detection was actually formerly before that CDSS and AI. This was based on the image recognition, totally different algorithm that are used now by large language models. So if you look from the like a method perspective, then it's just another method. It's might be more precise, might definitely large language models or generative AI brings much more information in on our desktop. This is for sure. Is it right or wrong? Is it good or bad? We don't know yet.
Great, thanks. So I want one more hard question from the audience. We heard when AI goes rogue, how much does AI cost? One more from the audience. Please.
Yes, I have a question for Thailand, because Thailand is a host country of a lot of migrants from the neighboring country, and I can only imagine the hospital in the border area. They have to enter like lots of new and less standardized data into the system, which are then generated into different health authorities, and then we can make a better system for the whole country. And we have a PDPA in Thailand as well. So PDPA, to my understanding, please correct me if I'm wrong, is for the Thai citizen, but does it also apply to the migrants in the country? So this is the first one. And the next question is how is Thailand like planning to use AI? Because lots of migrants, both legal and illegal, they come to the hospital for the different reasons. So how is Thailand planning to use AI to fill the gap in this migration healthcare?
I was stuck on with your first question, so I didn't get the last one. But the question that you asked, I just want to repeat so that I'm sure that I got the question. Is that when we get the data from different hospitals, how can we make sure PDPA is compiled?
From migrants, it's about the cross-border, the migrants.
Yes. And so I think PDPA cover migrants somehow. It is applied across the board. I'm not sure because GDPR cover everyone in European, right? So we follow GDPR. The PDPA follow GDPR, and the one that we didn't cover is the one who diseases. Like if you die, you lost the PDPA, right? And that is what we understood. I understood, let's say. And getting data from 30 vendors across 900 hospitals in municipal public health, we have the problem with data quality because they came with totally different standards. But in the past 10 years, we asked them to export into a single standard we call 34-file system. So if they export into the same standard, we can combine all the data. And that is how we analyze the National Electronic Medical Record in the past. And we are going to more standardized way to do that. But that is very difficult because the 35 folder system is kind of a barrier to adopt national barrier to adopt international standard because we think it's too much cost to change from the national standard to international standard. Okay.
Great. Thank you. We've come to the end. Before we do, I've asked our speakers to just end with one sentence. What would be their key takeaway or recommendation when we are talking about answering the question? We've answered that already, but what is their key takeaway or recommendation for appropriate, safe, effective use of AI in healthcare? 30 seconds. We'll go down the line.
Less than that, Mark. Ensure trust. Thank you.
Yeah, I prepared the sentence. Yeah, to advance AI in healthcare, we need secure data sharing system and clear regulations and incentives that encourage our stakeholders, including researchers, healthcare providers, and companies to adopt and utilize AI responsibly. Thank you.
Excellent. Trust, incentives. Patty?
Equity. And also like think about like linguistic equity. Think about things like research equity and being represented. Think about how can Thailand as a country contribute to the global AI ecosystem and data repositories and models, et cetera, so that you're a participant and not just a recipient of what is coming out of the US or China.
Excellent. Dr. Ross, Peter.
Right. My takeaway here is that we have to think first for what we use technology, and then look if we have this technology in place, rather than trust on technology only.
That's a lesson learned for digital, no matter what you're doing. User first, patient, provider, whoever the beneficiary, it's up to them, not up to the tech. Sorry, I had to break in there.
Municipal health is the motto of like, just do it.
Yes.
So we do it first, and then we will learn everything, like ethical, bias, and everything. So if we are not doing anything, we don't learn anything. So that's
Learning by doing, just do it. Love it. Okay.
And my key takeaway for action, successful healthcare AI should be rely on a secure data, strong governance, and inclusive design for trust and resilience.
Fantastic. Well said. Congratulate our speakers. Thank you for a wonderful panel. Let's get away from the fire before we burn ourselves. Over to the MC. Thank you, everybody. Thank you, panel.
Thank you very much, Mark and the rest of the panelists. And that concludes the second segment of today's session. Before we're going to leave this very room, Surakamhet, do you have anything else to add before we let everybody go home? It's been a long day.
Of PMAC 2025. So this is a great start, and we really thank you for joining us. We know it has been a long afternoon, but thanks for staying engaged with the Nicolas Cage, the excited Nicolas Cage spirit and energy. Want to thank all our speakers. Want to thank all of you for staying with us, and also the organizing team whom you've seen, who've been working quite hard to really design this, and also the communications team. So this is the start of a journey for us. We organize this as part of the WHO country cooperation strategy on digital health. We want to learn from other countries. We want to see what we can do better. So hope if you'd like to stay in touch, please do, in addition to sharing the insights from this session. So with that, we do want to close with a memory. So for that, I'll just hand it back to our MC, Manit.
Right, indeed. Thank you, Saudamini. We hope that today you guys have learned a bit more about AI and adoption.